Hello, and welcome to the Pediatric Brain Tumor Foundation's webinar, Exploring Targeted Therapies in Pediatric Brain Tumors. My name is Heather Held, and I am the National Family Support Programs Manager for the Pediatric Brain Tumor Foundation. We are honored to have you joining us today for this important webinar. The PBTF provides programs and resources to support families facing a pediatric brain tumor diagnosis throughout their journeys. We will provide links to some of these programs and resources at the end of today's webinar. Before I introduce our presenter, I have a few guidelines to review. You are muted for this webinar and your video is disabled, but we welcome questions during and after the opening remarks. Please type your questions into the Q&A feature found at the bottom of your Zoom window. We will not get to every question today, but we will try to get to as many as possible. Dr. Jason Fingazaro is the Director of Developmental Therapeutics and Medical Director of the Clinical Research Office at the Aflac Cancer and Blood Disorders Center of Children's Healthcare of Atlanta. Dr. Fingazaro is also Associate Professor of Pediatrics at the Emory University School of Medicine and the Carter S. Martin Endowed Chair. As a clinical member of the Pediatric Neuro-Oncology team, he specializes in treating children with central nervous system malignancies, including brain and spinal cord tumors. Dr. Fingazaro is a member of the Children's Oncology Group Brain Tumor Steering Committee, serves as the Vice Chair of the Pediatric Brain Tumor Consortium, and partners with pharmaceutical industry on investigator-initiated trials. Dr. Fingazaro's primary area of research is the development of early phase clinical trials, novel therapeutics, and relevant biologic correlates in an effort to improve survival outcomes and minimize toxicities. Within pediatric brain tumors, his research has focused on two main areas, low-grade gliomas and central nervous system germ cell tumors. It gives me great pleasure to introduce to you today, Dr. Jason Fingazaro.
Hello, everyone. Thank you so much for having me. Can you all see my screen? I'm guessing that's a yes. Well, first of all, thank you again for having me. You know, I've had the great opportunity to work with the Pediatric Brain Tumor Foundation on many projects over the years. We were just talking before the call on some of the camps I've been able to go to and some of the talks I've been able to give. And I've just always been grateful for the Pediatric Brain Tumor Foundation. And I'm very excited to present this topic to all of you today. So I was gonna start by telling you a little bit about who I am, but Heather just did that, so I will not bore you. But fortunately or unfortunately, what most people seem to know me by is my crazy green glasses. So you can see I'm wearing them today. My crazy green glasses, you can't miss me in a crowd. But recently I was outdone by one of my patients who recreated my glasses using Legos. And I think I want to go to market with these because those are a pretty good looking pair of glasses. This is my patient Aiden, whose father you're going to hear speak later on today. Okay, so let's get started. Today, what I really want to do is give you a general overview and explanation of what targeted therapy is. And then what I hope to do is give you a few examples in the brain tumor world and pediatric brain tumor world in particular. So we'll talk a little bit about low-grade gliomas, we'll talk about high-grade gliomas, and then we'll talk about a diagnosis that many have heard of called diffuse intrinsic pontine glioma, or DIPG. And then briefly, I also wanted to end by talking a little bit about immunotherapy, since as many of you know who are parents and family members, this has become a hot topic and we have a lot more therapies that are involving our own immune system. So I'll talk briefly about that, and then I'll give one example of an immune therapy. So let's just start with a basic, simple question. What are targeted therapies? So targeted cancer therapies are drugs or medicines that block the growth and spread of a cancer by interfering with a specific marker or molecule that may be on the cancer cell surface. So sometimes we refer to these as molecular targets. And when they make this blockade of the abnormality on the cancer cell, that will help stop the tumor from growing, will stop progression, and stop spread to other parts of the body. So you probably have heard the terms Molecularly targeted drugs, molecularly targeted therapies, precision medicine is another way that we refer to it. So another important question is, how do these therapies really differ from classic chemotherapy? So as I mentioned before, targeted therapies act on a very specific marker that is present on a cancer cell that helps it to grow and propagate. Whereas chemotherapies actually act on all rapidly dividing cells in your body. So that includes some of the side effects that we see with classic chemotherapy, because some of the cells that rapidly divide in our body are our hair follicles, for example, our gut, and even our white and red and platelet cells. And so because chemotherapy affects all of those rapidly dividing cells in your body, some of the side effects that we see is that some children might need transfusions. Patients will lose their hair, or they'll have nausea and vomiting and diarrhea. But that differs from targeted therapies, which are deliberately chosen to interact with an abnormality on a tumor and act as a reservoir to block that abnormality. And it's not to say that targeted therapies don't have side effects, but the side effects are very different from the ones I just mentioned with classic chemotherapy. Another thing that may not be as important, but sometimes people throw around these terms, is targeted therapies are often what we call cytostatic. So that means it blocks the tumor from growing more and proliferating, whereas standard chemotherapies are usually cytotoxic. And what that means is that it actually kills the tumor cell. Now this can vary, but in general, that's how targeted therapies differ from classic chemotherapy. So the way I kind of like to think about it in a very general term is that classic chemotherapy is more like a bomb going off. In a way that's good, because the bomb can attack the cancer, but unfortunately the bomb also has abnormalities arise from it because it kind of blows up everything. And that's why we get a lot of the side effects that we see with classic chemotherapy that I mentioned before, the hair loss, the nausea, the vomiting. Whereas targeted therapy, I think of more as a bow and arrow. You're actually targeting something very specifically. And so you don't have a lot of those systemic or organ side effects that we have with classic chemotherapy. Now, again, as I mentioned, targeted therapies still do have side effects, but they're very different than the side effects that we see with classic chemotherapy. So in order to have a targeted therapy, what is important? Because obviously it's been many, many decades and we're just starting to see targeted therapies now. So what is actually necessary for us to have a targeted therapy for a specific type of tumor? So first of all, we have to understand that specific tumor very well. We need to understand some of the molecular and biology and the pathways that drives the tumor. Once we understand that, which for many of our brain tumors, we have come a long way in the last decade, we also need to have a drug or a chemical that can block that pathway that we know is driving the tumor. Again, even though we have the drug and we have the understanding of the pathway, we have to be able to give this medicine in a safe way to humans. And usually this is done by testing in adults first, and then this often goes down to testing in children. We also need to understand a little bit about the drug's side effects. So we see how it treats animals in the laboratory. We need to understand the best dosing of the medicine, and we need to understand how it works in the body. All of these things are very important before we just start giving medicines to patients, because we could cause more harm than benefit by some of our targeted therapies if we don't understand them completely. So I kind of made a little picture here, and I hope it's helpful to some people. For me, sometimes words aren't always helpful and pictures are more helpful. So if you think of a tumor cell, and a tumor cell has an abnormality on it, and that abnormality is that Y in gray, that abnormality on the tumor cell is what's helping the tumor to grow. And so it gives it the green light to keep growing and growing and growing, and then maybe even spread to other parts of the body. Now, if we think of something with targeted therapy, we have that same tumor cell, but then a targeted therapy goes and blocks that Y, and it gives it a stop sign. And now the tumor can no longer grow, can no longer propagate, because that little pink triangle is blocking that Y, and that's the theory behind a targeted therapy. So I want to make a few key points that I think are really important. First of all, although we have a target on a specific tumor and we have a medicine that can block that target, it may not always still be effective for a specific patient or a specific tumor. The reason behind this is because we're still learning a lot about our tumors and what makes them up and what drives them. And sometimes, even though in the last picture I showed you that these tumor cells have that one Y on it, they actually can have many Ys. They can have a Y on them, an X, a Z. And so if we only block the Y with one drug, all of those other pathways may drive the tumor to continue to grow. So that's one reason that sometimes a targeted therapy doesn't work, because a tumor has many ways of causing it to grow. Another reason is sometimes we have a targeted therapy that the tumor outsmarts. And even though the tumor may initially stop growing, it starts to learn how to overcome this targeted therapy and develops what we call resistance to the drug. And so again, even though we have all the things in place for a targeted therapy to be successful, unfortunately, it doesn't always work. And sadly, for many of our tumors, we have not found the best target or the best therapy to block the tumor from growing. So now I want to move on to the section where I talk a little bit about specific examples of targeted therapy in our brain tumor population in children. So we'll start with low-grade glioma. This is an area where I focus much of my research on. And low-grade gliomas are the most common brain tumor that we see in children. So sadly, we see a lot of children with low-grade gliomas in our clinics on a regular basis. And there are a variety of histologies, meaning what it looks like under the microscope. One of the most common one that we refer to is called pilocytic astrocytoma, but there's a lot of other names and I've listed some of those there. But in general, these are slow-growing tumors. And the World Health Organization calls them low grade because they're grade 1 and 2 versus higher grade tumors that we classically call grade 3 and grade 4. So if we look at all the brain tumors in this pie graph that we see in children, I've broken it down by the most common ones that you may have heard of. That purplish blue color is all glioma tumors or astrocytomas. And if we break it down into just the low grade, it's about 40 to 50% of all the brain tumors we see are low grade. So it's a big fraction of the children who have brain tumors worldwide. Now, classically for low-grade gliomas, the best way to treat it is try to get it completely out with the surgery. And so we rely heavily on our amazing neurosurgeons. But sometimes, because where the tumor is located in a very sensitive part of the brain, we cannot remove the tumor completely without causing significant side effects. And so in those situations, we rely on other therapies to treat these tumors. And classically, we use classic chemotherapy. The chemotherapies that we most often use for low-grade glioma is a combination of two meds called carboplatin and vincristine. You can also use one medicine by itself called vinblastine. And then there's a combination of medicines that is sometimes used called TPCV, thioguanine, procarbazine, CCNU, and vincristine. All of those are very effective strategies. And in general, when we treat children with low-grade glioma with chemotherapy, about 2/3 of patients will have stable disease, meaning the tumor does not grow anymore, or they may even have shrinkage of their tumor. But unfortunately, there's another third of patients that despite those therapies, their tumors will continue to grow. And so for those children, we really need alternative strategies and alternative mechanisms of treating the tumor. So fortunately, and again, this is something that I have the honor of being a part of, is we've learned a lot about low-grade gliomas. And remember, I told you there's different pathways that drive cancers and specific tumors. We have learned that in low-grade glioma, there's one specific pathway called the MAP kinase pathway that seems to be driving the tumor to grow in most low-grade gliomas. And specifically, there's an abnormality in a part of this pathway called BRAF. And you may have heard of this. Many of you have patients or children or friends who have low-grade gliomas. This BRAF abnormality is also common in an adult tumor called melanoma, a skin cancer. And so we've learned a lot from our adult colleagues who treat melanoma. So there's two types of abnormalities that we most commonly see in low-grade glioma. There's one called a BRAF fusion and one called a mutation. The fusion is much more common, but we still see about 10 to 15% of our patients that have a mutation. For our talk today, it's probably not as important to know what those specific differences are, but that they are abnormalities in the tumor that we are able to target. So I put this complicated pathway up here, not to scare anyone away or to make it too complicated, but basically what this is that MAP kinase pathway that I told you about. So what happens is this is the inside of a tumor and a tumor cell. And if this pathway, all those arrows, if they're allowed to go unregulated, the tumor continues to divide and continues to grow. But you can see some of those things I talked about. BRAF, for example, is in that pathway in a pink diamond. And now we do have medicines available that can block various levels of that pathway. So now we have medicines that can block BRAF. There's a medicine that can drop and block lower down something called MEK, so a MEK inhibitor. And then there's even newer drugs that we're still learning about that can block the area called ERK, E-R-K, or ERK inhibitors. But you can see, if we go backwards, if we block any one of these areas of this pathway, we lead to blockage of tumor growth and tumor death. And so that's what a targeted therapy is doing. It's blocking one of those specific areas. So there are many ongoing studies with many groups. So there's one ongoing with the Pediatric Brain Tumor Consortium, with the Pacific Neuro-Oncology Consortium, Children's Oncology Group, the European group, PSYOP, and then pharmaceutical companies, and even some small institutional trials where you can go to a local institution that they're using some of these newer medicines, BRAF inhibitors and MEK inhibitors, to treat low-grade gliomas. Fortunately, this has been really the paradigm of success. We've seen a lot of wonderful responses in children who have not done well with classic chemotherapy. Their tumors grown after classic chemotherapy, and we put them on one of these agents and their tumor responds or stays stable. We still have a lot to learn though, unfortunately. We don't really know how long to treat them. Do we treat them for 1 year or 2 years on these molecularly targeted therapies? And we don't know some of the late side effects. So even though we understand the side effects that the children have when they're taking the medicine, we're not sure what's going to happen in 5 or 10 years from now after they've been on these medicines for a long period of time. So those are areas of research that are very, very important. I just wanted to show you one more graph to kind of hit home this point of success with targeted therapies in low-grade glioma. So this is a trial called Pediatric Brain Tumor Consortium Trial 29, and it was a trial for children who had progressed after standard chemotherapy, so their tumor had come back, and then they were treated with an oral medicine called selumetinib, which is a MEK inhibitor. And the way you read this graph is that zero baseline is what their tumor size was at the time they started the new medicine. And each bar is a patient. So if the bar goes downward, the tumor shrunk, and you can see how much it shrunk, 80, 60, 40%. And if the bar goes upward, you can say that the tumor grew on the trial. So you can see the majority of the patients on this trial had shrinkage of their tumor, ranging anywhere from a few percentage points to all the way up close to 80 or 90% shrinkage of their tumor, which was a great success. And we were very excited by this. And this trial actually has led to a large trial now comparing the standard of care, carboplatin and vincristine, to this targeted agent, selumetinib, in patients with newly diagnosed low-grade glioma, meaning they haven't seen previous chemotherapy. But you can still see on this graph too, there are a fraction of patients whose tumor grew despite giving the targeted therapy. And this is the group of patients that we still need to learn more about and understand with our research. So now I'm going to move on to a high-grade glioma. Now, this is kind of the sister to low-grade glioma, but unfortunately a much more aggressive tumor. There are two very common types of high-grade glioma that you may have heard of, one called anaplastic astrocytoma and one called glioblastoma multiforme. These tumors are much more common in adults, but we see them in a fraction of children as well. The thing that's very important is that even though under the microscope they look almost the same when you compare an adult to a child with a high-grade glioma, they are very, very different. So the biology of the tumor, those markers I told you about that can reside on the surface of the tumor, they're very different between adults and children. And the way children respond to therapy and what is an effective strategy is different in adults and children. And unfortunately, compared to low-grade glioma, where most children will have stability and response of their disease, high-grade glioma is much more aggressive in children, and most children will have multiply recurrent disease, and we are not able to cure many of these patients, unfortunately. So if we look at high-grade glioma, again, on that pie chart that I showed you previously, the gliomas and astrocytomas are in that purplish blue color, and the high-grade glioma are, again, a smaller percentage, about 10 to 15% of patients. So how do we classically treat these patients? So classically, we try to get as much tumor out as possible, again, similar to low-grade glioma. Unfortunately, for high-grade glioma, this is much more difficult because the tumor has these little extensions that extend into the brain, so it's hard to get all of the tumor out. But we still do our very best with our amazing neurosurgeons to resect as much of the tumor as we can. And then the standard of care for high-grade glioma is for a child to get what's called radiation therapy. And that can either be light beam energy or proton beam energy, which I know many of you have heard of proton beam radiation therapy. And we give the radiation focally to the tumor. And usually this is combined with a medicine on the clinical trial. And that could be a medicine that is a chemotherapy, a targeted therapy, or sometimes an immunotherapy. But the backbone is always radiation therapy with rare exception. And that exception is if the child is very, very young, we sometimes treat them a little bit differently. Again, unfortunately, these tumors are much more aggressive than what we talked about when we discussed low-grade gliomas. So similar to low-grade gliomas, though, we have learned a lot about high-grade gliomas and their molecular makeup and what drives the tumors. The thing that's been difficult for us as researchers is, unlike low-grade glioma, where there seems to be only one or two pathways that drive the tumor, and when we block that pathway, the tumor stops growing. In high-grade gliomas, we've discovered that there are multiple pathways. And so remember, I told you sometimes targeted therapies don't work because if we only use one medicine to block one pathway, the other pathways are still able to allow the tumor to grow. So I've listed some of the more common abnormalities that we see in high-grade gliomas. EGFR, ATRX, you can also get something called H3F3A, G34R. It's kind of like alphabet soup. The important thing is they're very unique and different abnormalities. The one I'm going to talk a little bit more about, because we have some medicines to target it best, is the V600E BRAF mutation. So remember, I mentioned this with low-grade glioma as well. But interestingly, about 10 to 15% of patients with high-grade glioma will also have a BRAF V600E mutation. So if we see this in about 10% of patients, and these medicines are available, many researchers started wondering, well, what if we start treating these children with these BRAF inhibitors? How would they do? And what happened is many case reports around the country, a few written out of Boston and Dana-Farber Cancer Institute, showed that children who had already received radiation therapy and the tumor started growing again, if you gave them this directed therapy against BRAF, if their tumor had a BRAF V600E mutation, their tumor began to shrink. Now, the duration of the shrinkage was not always long-lived, but it was the first time that we saw medicine work so effectively in causing high-grade gliomas to shrink. Again, the duration is short, probably because the tumor starts to develop some resistance. So because of this finding, and now that we understand that we can identify these abnormalities in this tumor, there's now a very large COG trial, Children's Oncology Group trial, specifically for that small group of patients who have a BRAF V600E mutation and have a high-grade glioma. And that new trial will be pairing radiation therapy with those molecularly targeted agents in newly diagnosed patients to see if we combine the radiation with these targeted agents, will those children have more successful outcomes? And we're very, very hopeful. The trial only began about a year ago, and so a small percentage of children are enrolled, and so we really don't know the outcomes yet. But as I said, researchers are very hopeful. I did want to show you one quick picture from some of the case reports. So on the left side of your screen, the red circle is around a tumor in white. And then this child whose tumor had a V600E BRAF mutation was treated with a medicine that was an oral medicine, a BRAF inhibitor. And you can see that many months later, the tumor shrank and disappeared completely, which is very exciting, as I said, in high-grade gliomas. Unfortunately, many of these patients, the tumor begins to develop resistance. And so this strategy of giving that medicine alone is not a long-term effective strategy. We're hoping by combining it with other medicines, we'll have longer duration of responses. And then I wanted to talk briefly about this tumor, diffuse intrinsic pontine glioma, that many people have heard about, because it's the tumor that unfortunately we have made the least progress with. And yet, as researchers, we try to push the envelope and hopefully do better for our patients and our families. This is an aggressive tumor that invades a part of the brain called the pons. It's a part of the brain stem. It represents about 10 to 15% of the patients that we see. And really the only known effective therapy is radiation therapy. No medicines, no targeted therapy, and no classic chemotherapy have proven effective in treating DIPG. So most children are treated on clinical trials using radiation therapy and combining them with new agents with the hope of benefit and in hope of improvement. There's also a very common abnormality in these tumors, and this is one of the reasons I wanted to talk about them. If we do biopsies on these tumors, which we have done much more recently, we see a mutation called an H3k27n mutation. It's a mutation in something called a histone, which is important for cancer cell division and replication. And we see this in 80% or if not more of DIPG tumors. So on the surface, this is very exciting because we've discovered something that we didn't understand about DIPG, and it looks to be a target. But unfortunately, to date, we don't have any specific medicine that targets it directly. Now, there are a lot of studies ongoing that are using medicines that seem to target the pathway in some way, and the results of those are ongoing. But we're hopeful that we could develop medicines in the future that more specifically target this H3k27n mutation so we can really do better for these patients, because right now the outcome has been very poor. I wanted to do this brief comment about tumor molecular profiling. So many of you who have children with brain tumors, or even physicians, there are many avenues to take in testing the tumor and its molecular profile. There are different companies and different platforms that do all different sorts of testing. What I would suggest to you is that you talk to your own neuro-oncologist or oncologist of what platform is being used locally and what be best for your child. And sometimes these reports come back, they can be hundreds of pages, and they give us all these abnormalities of the tumor. And it can be very exciting at first because it suggests many, many alternative therapies for a child who has a specific type of brain tumor. And we should be hopeful because they do give us alternative options for our children and our patients. But sometimes the options that are in those handouts and those written reports are really not reflective of a real life scenario, meaning there are not specific drugs that can target those abnormalities that are identified. Or, for example, the drugs that they tell us to use are not available outside of a clinical trial or may only be studied in adults. And so it becomes difficult to use these medicines when we have not used them in children yet. And so sometimes we can have a target and a medicine, but we truthfully can't use them in a child as of yet. But we're hopeful that we continue to discover more so we can use more and more medicines in our patients. And that kind of leads to this next slide. Are all targeted therapies available to our patients and our children? And the answer is, unfortunately, not all of them. There are some and many that are available. So some medicines are available on a clinical trial, and your child may be eligible for a certain trial locally or even at another institution. Sometimes some of the medicines are available for a physician to write for, and an insurance company may provide approval, and you don't need to be on a clinical trial. And then even more rare, you can sometimes get medicines through something called a compassionate use program. This is very dependent on the institution and the physician and the drug company. But sometimes if you have a very specific medicine and a very specific target in a tumor, you can write a protocol and get a compassionate use exemption from the drug company to use in a specific child. Again, I would talk to your own oncologist or neuro-oncologist about the possibility of this in a specific scenario. And then, as I mentioned briefly, there are just some medicines, no matter what, that we just don't have available to us for our patients. Either they haven't been tested in children, or they've been tested in adults and they seem to be too toxic and have too many side effects. And so that's why our research really needs to push forward to develop new medicines and new drugs for these children who right now don't have specific targets that we can use medicines on. And then lastly, I wanted to end by talking about immunotherapy on these last few slides. And I can see I'm going a little bit over, so I'm going to kind of go through these quickly. As you all know, immunotherapy is a type of cancer treatment that really relies on our own body's immune system to fight the cancer, similar to how you would have your own body fight an infection, for example. And as I said, this could be a lecture in itself, so I'm just going to give you a brief overview. But really, an immune therapy can educate your body to recognize cancer cells. It can boost your own immune system, or it can provide additional components to your immune system that help it work more effectively. There are many, many different types of immunotherapies, and I'm sure many of you have heard of some of these. Vaccines, there are viruses that can infect the tumor cell and cause the immune system to react. Sometimes you've probably heard on the news the polio virus or the herpes virus being used for this. There's something called adoptive cellular therapy. So in leukemia, something called CAR T cells has become very popular. And now in brain tumors, we're starting to use it as well. And basically what that is we take the T cells out of the body, our normal T cells, and we educate them to attack a specific marker on a tumor. Then we give them back to the patient, and then the T cell goes and finds the tumor and ideally kills it. And then there's many medicines that we can use that can boost our immune system. All of these different strategies are being tested across the country and by many consortia. So I'm just going to give you one brief example, and that's what we'll end with today. This is an example of a medicine that's being used as an immunotherapy. It's a medicine called Pembrolizumab, and there's a trial right now through the Pediatric Brain Tumor Consortium. It's called Trial 045, and it's treating patients with recurrent high-grade glioma, ependymoma, and medulloblastoma. And really briefly, pembrolizumab is an antibody, and it blocks something on the cancer cell called programmed cell death. And that's one of those little markers that sticks off called PD-1. Usually you have that on your normal immune cells as well. And what their function is it stops the immune system from going too much, meaning it doesn't want the immune system to attack your own body. And so what that PD-1 does is it kind of puts the brakes on the immune system. And what pembrolizumab does is it helps you take your foot off the brakes and allow the immune system to rev up and fight tumor. So once again, I have a picture, and hopefully this is helpful. So in general, you have your T lymphocyte, which is the immune cell of your body, and it will interact with the tumor. And at first, when it interacts with the tumor, it recognizes the tumor as abnormal, and it tries to beef up the immune system by releasing proteins and making more cells to fight and kill the tumor. But unfortunately, even though we have that initial interaction, there's also this secondary interaction, which I just mentioned to you, the interaction of this PD-1 or programmed death ligand. And what happens is when that PD-1 interaction occurs between the tumor cell and your own immune cell, it puts the brakes on the immune system and it downregulates the immune system and tells it, stop attacking because we're worried that you're attacking your own cells. So the medicine pembrolizumab comes in and blocks that interaction. It blocks that PD-1 and PD-L1 interaction. And so it takes the foot off of the brake and allows the immune system to rev up again. And because of this, you have many more immune cells being created in the body and attacking cancer cells. So that's just one example of an immune therapy. Many of the other immune therapies I mentioned, like vaccines and viruses, they work in variations of this, but I just wanted to give you a brief example. So in conclusion, we've kind of had a whirlwind tour of targeted therapies, but I wanted to let you know that, targeted therapies are something that we know a lot about, are present in patients with pediatric brain tumors. We now understand a lot about our patients and their tumors and the targets that those tumors have, and we're able to use a lot of the medicines to try to target them. Unfortunately, with the exception of the low-grade glioma world, which I talked about, we're not having tons of success. But I think as we move forward, we're very hopeful that we will have more success because now we can start pairing these targeted therapies with classic chemotherapy, with radiation therapy, and maybe even with immune therapies. And by putting these all together, we may find what's best for our patients and really do better for our patients and their families, not only improving their survival, but improving their quality of life and minimizing the side effects that they experience. So that's it. I want to say thank you to everybody. I want to thank the Pediatric Brain Tumor Foundation for inviting me, my teams at PBTC, COG, and here at Emory. This was my team locally. We did one of those escape rooms as a team building activity. So you can see we're kind of a bunch of silly people here. But that's it. I want to say thank you again. And really, it's been a pleasure, and I'm happy to take any questions.
Thank you, Dr. Fangusaro, for your presentation. We'll move into our Q&A portion of the webinar now. My name is Kathy Riley. I'm Vice President of Family Support for the Pediatric Brain Tumor Foundation. It gives me great pleasure to also introduce two parents who will join Dr. Fangusaro to answer questions from all of you. Parents offer a valuable perspective on the panel as experts on their child's journey, knowing firsthand the unique challenges families face during treatment. Alina Kupelian's daughter, Sophia, was diagnosed with optic pathway glioma when she was 3 years old. In the beginning, Sophia started receiving conventional chemotherapy to shrink and manage a very large tumor, which at that point was rapidly affecting her vision. A year after diagnosis, Sophia qualified for a targeted therapy trial. She has been on the same targeted therapy for the last 3 years. In his professional life, Edgar Martinez is an industrial engineer dedicated to sales and project management. In his personal life, Edgar is currently caring and advocating for the health of his son, Eden, who is fighting a brain tumor. Through the experience of multiple medical trials, Edgar believes there must be a better way to test medicines and track patients to better understand the effects of what works and what does not work for each individual patient. We now welcome questions from all of you. I see we received some already in the chat feature on the Zoom window. So we'll begin with some of those. And I welcome our panelists, Dr. Fangusaro and Alina and Edgar. Please join us.
Hello, everyone.
Hello, everyone.
Dr. Fangusaro, I'll start with you. A question that we've received in the Q&A. Do you have any specific advice on treatment of pilocytic astrocytoma with solid tumors and diffuse areas?
Yeah, so it's a great question. So in general, you're right. We see that many patients have a low-grade glioma or pilocytic astrocytoma in one location, and we're treating that area. But there are some patients, many who I treat myself, that have tumors throughout their brain and spine, and it's a low-grade tumor. And actually, we've treated those tumors very similar to tumors that are localized. So initially, they are typically treated with classic chemotherapy. And then many of those patients have gone on to some of the targeted therapies, which I discussed on my presentation. And even in those patients with diffuse disease, we have seen responses. So for example, if the patient's newly diagnosed, they would be eligible for the new Children's Oncology Group study, where they're comparing the classic chemotherapy carboplatin and vincristine to the new medicine selumetinib. Now, in patients where alternative therapies have not worked or their tumor has progressed, there are many other targeted therapies that they may be eligible on a clinical trial. But in general, we still treat those children very similar to a patient who has a tumor in one location.
Thank you, Dr. Fangusaro. That was a great answer. I'll move to one of our parents now. Edgar, I'll ask you, could you talk about how do the side effects from targeted therapy compare with the side effects of conventional therapy? How have you seen that from the parent perspective?
Sure. No, I appreciate the question. I think that Dr. Jason touched on it during his presentation, and it really boils down to toxicity, correct? And so the targeted therapies are really minimal in toxicity, so the children are able to tolerate it better. We didn't really see much of any symptoms at all when our son was being treated with the targeted therapies. Unfortunately, Aiden's tumor did not respond well to the targeted therapies that were mentioned. So we had to move on to a different therapy. But all in all, the symptoms were very minimal, if any at all.
Thank you for sharing that, Edgar. Dr. Fangusaro, I'll move back to you. We have a question about molecular profiling and why aren't all patient's tumors going through molecular profiling when the tumor is harvested. Can you sort of talk about the importance of that and why perhaps not all tumors are being molecularly profiled?
Yeah, it's a great question. And I think part of it is because our field is evolving a little bit. And so some institutions, it is part of their standard of care and research to do molecular profiling on every tumor. Some institutions do not do it. And I think the reason why it's not more universal is because in many diagnoses, unfortunately right now, it doesn't change what you would do at the start of therapy. It oftentimes has more implications of what would happen if the tumor grows after standard or classic therapy. And so many institutions will consider doing it at that point. They'll use the tumor tissue that was collected initially, or if the child has another resection, to use that for molecular profiling. But I'd have to say we're kind of in this era where it's all evolving. And so, you know, some institutions will do it right away. Some institutions will wait. I don't think there's a right or wrong answer. I do think, as I said, sometimes when you do it right away, you get a lot of information that may not be applicable to your child. And it depends on the personality of the family, and you guys can answer better than I. Some families want all that information, and that's helpful, even if they know they may not use it. And some families, it becomes overwhelming and it's too much information if they don't think that they need to approach it. So, but in the medical world, I can say it's still evolving, and, you know, some families do and don't. I do think as the tumor recurs, though, it becomes very helpful to find new therapies that may be beneficial for your child.
Thank you. Thank you for that. Alina, I have a question that I'll ask you, again, from the parent perspective. What do you know now that you wish you had known before beginning targeted therapy with your daughter?
Thank you, Kathy. I don't think there is anything that we've learned that's, you know, made us think, oh, maybe we should made a different decision. We've had a very, very positive experience with targeted therapies. It's been night and day in terms of especially so for Sophia, in terms of her lifestyle. She's been able to sort of carry on like a regular child, taking the medicine every day at home versus having to go to the hospital every week, spending hours there. And like Edgar was saying, side effects are also very different and much more manageable and mild. The biggest thing I think we've learned that we know now we didn't know before was we were recently told that 2/3 of the children that have been on these medicines that stopped taking it, the tumor has been stable. For me, this was a very significant information because, you know, as a parent, you think, well, how long are we going to stay on this medicine? And initially we were told, you know, and still, I guess nobody knows, right? But I think the fact that we can actually now decide to pause and there's a chance of this tumor not growing and possibly be off medication is a very good information. So I think in the near future, we'll be ready to do that.
Thank you, Alina. Dr. Fingazaro, another question I'll send your way. Do targeted therapies carry risks of long-term side effects?
That's a really excellent question. And I think we don't know the complete answer yet. And that's something that many of us in the low-grade glioma world are worried about. Not that we think for sure it's going to happen, but I think we've been so excited in the low-grade glioma world that we're seeing responses and stability, and we should be. I mean, we're making huge gains for these children that you just heard about. The quality of life is much better for Sophia, but we do worry that if children are on these medicines a long time, in 5 or 10 years, will they have different side effects that we're not sure about yet? And so really what our job as researchers is to continue to follow those children very carefully and make sure that nothing's happening that we need to document and hopefully prevent. So the answer is really to be determined. We're still needing to understand more about these drugs. And it doesn't mean that we shouldn't use them, we should, but we just have to be very cautious and monitor our children very carefully.
I have another question that, Edgar, I'll ask you to jump in, but Dr. Fangusaro, this may also be something from the medical side of things that you could shed some light on as well. So it's a question about insurance coverage. How difficult or not was it to get this covered by insurance? And Edgar, maybe you could speak to that from the parent side of things. And then Dr. Fangusaro address it from the healthcare side.
Yeah, so from our end, it was pretty painful. Well, it was painless in the sense that that we were able to work with most of these. They are on clinical trials. Most of these medicines are in clinical trials. So a lot of them, there is no cost to the parent and to the family to be able to receive them. The painful part of it is that you just don't know which one is more efficient than another, right? So you are given choices depending on the clinical trial that you're looking to get. While the economical part of it may not be a difficulty or a big hurdle to overcome, I think the biggest thing, and this is kind of taking a different route from the question you asked, but the biggest thing for us was, how do we know that we're making the right choice in using a certain type of targeted therapy for our child? Which one has a higher percentage of working or not? But from the insurance standpoint, it was not an issue. And when I then had to be on a MEK inhibitor, which was a targeted therapy, Dr. Jason was able to help us to contact the pharmaceutical company and be able to get the medicine under compassionate care and a reduced cost as well.
Yeah, and I would just add to the financial piece, it really varies. And insurance, in general, if they're on a clinical trial, like Mr. Martinez mentioned, usually that is not something the family has to worry about. Those are covered by standard of care and by the clinical trial. If it's off study, that's when it becomes a little more difficult. I think in this era, if we provide the insurance companies with the rationale and the data, and we do a little more personalized talking with the physicians at the insurance companies, we're able to overcome some of those hurdles. But it's not uncommon that the first time we request a medicine that are targeted therapies, that we get a refusal. And it just sometimes takes a little bit of local work and pushing to say, well, wait a second, this isn't an adult, this child has a very specific tumor, this is why we need the medicine. And, you know, knock on wood, we've been successful here and in many other institutions that we've been able to get coverage for many of the things that we think are, you know, appropriate options for our children.
Thank you both for that. We have had a number of questions in the chat about specific tumor types and specific mutations, Dr. Fangusaro. So I think a general question that may help answer some of those is, how do I go about finding out if my child is a good candidate for targeted therapies?
Yeah, it's a great question. I think the first thing is to, you know, touch base and open that conversation with your primary oncologist and neuro-oncologist that you're working with. Some tumors, for example, if they don't have a biopsy or they don't have a surgery, we don't know the molecular makeup of those tumors. And those are harder to target because we're not sure what we're targeting. But even in those scenarios, there are some children, for example, with a diagnosis called neurofibromatosis who have low-grade gliomas. And we found that even though we don't always know the makeup of their tumor, using some of those targeted therapies has been an effective strategy. But I would say at first, I would have that discussion with your local oncologist, neuro-oncologist, and understand what is the abnormalities in your child's tumor. And if standard therapy has not been an effective strategy, is there alternative strategies? And bringing up those questions, is targeted therapy an option? Is immunotherapy an option? And getting that information and, you know, and guiding you to help make the best decision.
And then we do have an immunotherapy question as well. Are there any current immunotherapies used in the low-grade glioma world?
So I don't want to misspeak. In general, far and away, we have not used low-grade glioma immunotherapy a ton, but I think there may be one or two small local trials where low-grade gliomas have been included. For example, I think there was a vaccine trial in New York where they were including some children with low-grade glioma. But in general, the far majority of trials with immunotherapy of late have been on the more aggressive tumors. So high-grade gliomas, medulloblastoma, ependymoma. But I bet you will start seeing more low-grade glioma immunotherapy trials because, as I mentioned, there are this fraction of patients who don't respond to classic chemotherapy, and then a fraction of those patients who the targeted therapies don't seem to be the best option. And so we need to start figuring out what we can use to help those children. And I think, as I mentioned at the end of the talk, it may be a combination of therapies, or maybe it will be immunotherapy, which we have not explored extensively in low-grade glioma.
And then we've also had some questions about side effects along with targeted therapies. And are there any effects, Dr. Fingazaro, that you've seen that would be a reason to stop the targeted therapies?
Yeah, it really depends on the targeted therapy, but there are definitely some side effects that become too toxic and the child needs to come off the therapy. So I can just talk briefly about one that we talked about, the selumetinib or the MEK inhibitor. Very, very rarely, it can cause cardiac or heart dysfunction. And so many of those children are monitored with echocardiograms or ultrasounds of their hearts and EKGs. If their heart function begins to decrease to a significant amount, we have to stop those medicines and observe them. Most of those children recover once we stop the medicine, and sometimes we can restart it at a lower dose. But there can be some rare, very aggressive side effects that we have to monitor. In general, some of the targeted therapies, like in the low-grade glioma world, we deal with our rashes. Patients can get infections in their nail beds, infections in their toes. They can sometimes get dry mouth, nausea, vomiting, and diarrhea. But as both parents already alluded to, most times we can kind of control those in most patients and they have a better quality of life. But there are rare patients, because of who they are maybe and their makeup and their specific tumor, that they can have more extreme side effects. So I don't want to get too long-winded, but you can have two children that look exactly the same in terms of their tumor and the tumor molecular profiling, and one child has a very severe rash and another child doesn't, and we don't understand why yet. We're trying to learn that better, but it can vary. But in general, as the parents mentioned, it's much better tolerated than the classic chemotherapy.
And then we have one final question, Dr. Fangusaro, from a healthcare professional that actually came in at registration that I think is a nice a summary to what we've discussed today. And that is, what goes into the doctor's clinical decision, your clinical decision making when offering targeted therapies over the standard of care?
Yeah, it's a great question. And I think each person is a little different. I can give you my approach that in general, off of a clinical trial, we often will provide the patient with the standard of care, which we know has a long history of success depending on the diagnosis. If there is a clinical trial exploring a targeted therapy and we can monitor the child carefully in a fashion where other children across the nation are also being treated, I will often consider that as an alternative. And if there's a trial available for a family, I really kind of feel it's our, duty to at least mention that to the family, especially if it's local, because they need to be a part of that decision process. But there's very few, especially at the time of diagnosis, where you're using complete alternative therapy and standard of care. It's oftentimes, as I think what Mr. Martinez alluded to, we get to this place where there's no one right answer, and there's maybe 2 or 3 clinical trials. And that's a much harder pathway to decide, okay, like, do I go down this oral medicine or this oral medicine? They seem somewhat the same. And I totally hear what Mr. Martinez is saying, obviously because we work together, but also because as a physician, I don't have the answers that a family wants. They are hoping that I can say, well, this targeted therapy was 10% better than this one, or this one more children responded. But most of these medicines, they're so early in development, we don't have that data available. And so we have to base it on the knowledge we have. And sometimes there are some more rational choices based on the abnormalities within the child's tumor and what medicines are available. But sometimes we just have to choose what we think might be best. And that, as I said, goes along with the family's decision. So Mr. Martinez has heard me say it. Sometimes if I don't know that there's a difference between two therapies, I start looking at the side effect profile, because I want the child's quality of life to be just as good if I don't think there's any difference. Now, of course, if I knew that one therapy was way better, I know most families would say we're willing to accept some of these side effects. But if I have no data to prove that one is better than the other, I always try to err on the side of giving the better quality of life to the child. But again, that really has to be a discussion with the family. Hopefully we're out of the era that, you know, it's the physician telling the families what to do. It really needs to be a conversation where we're all providing information back and forth and doing what's best for the patient.
Thank you so much. I think that is a perfect way to wrap up our time. And I so much appreciate our parents being a part of this conversation today.
Absolutely.
It's been a great conversation. We have so many deep and meaningful questions that were put in the Q&A chat that we are not able to answer today. I encourage all of you to fill out the survey that will come your way afterwards. And if there are questions that you had that weren't answered, you can certainly include them there as well. And I'll ask Heather Hell to come back and wrap up our time together today. Thank you.
I'd like to thank Dr. Jason Fingazaro for his time today and for sharing his expertise and experience with us. Such a valuable time of learning for all of us on this webinar today. And thank you, Edgar and Alina, for providing meaningful and personal insights from both of your journeys. And Kathy, thank you for leading that discussion today. I'd also like to thank you, our attendees, for your participation and thoughtful questions. The PBTF is here to help you no matter where you are in your journey. We'll be sending you a link to the recording of the webinar and also send the slides at the email address that you registered with. The PBTF has several resources to help with your educational and survivorship needs. The Survivorship Resource Guidebook provides comprehensive information and practical resources for families, for survivors and families as they navigate the survivorship journey. This valuable resource can be requested in hard copy or downloaded online. The peer-to-peer mentor program matches pediatric brain tumor family members with trained mentors who have experienced the challenges of a brain tumor. And finally, our family support webinars, as you experienced today, feature carefully chosen experts with information and resources relevant to the brain tumor journey. Subjects in the coming months include the sibling journey, transition readiness, and engaging with the PBTF community. Past and upcoming webinar information is available on our website. Thank you again for attending our webinar today, and please feel free to reach out to our family support team at the PBTF if there is anything we can do to help you. Enjoy the rest of your week.